Certainly, if you want to forward the slide a little bit. So I'm just going to start out by telling you a story of one of our patients, 26-year-old who 5 years ago presented with severe headaches and was found to have a left brain mass. He underwent some very specialized imaging, of which I've put some screenshots in the lower left-hand corner for surgical planning, and a gross total resection of this tumor that you see in the upper right quadrant of the picture as that white rim with the dark center. So that was completely resected. The pathology returned as glioblastoma. It had some specific genetic markers that were felt to be pertinent for this gentleman, IDH mutant and an FGFR fusion transcript. He went on to receive what is considered standard therapy with radiation and chemotherapy. During the time of his treatment, he was able to continue his college studies. He graduated with honors, and he is working in his field of study. And 5 years now after diagnosis, he has had no tumor recurrence. So while this may seem like a very simple story that doesn't really highlight too much, do want to point out several things. So this gentleman had the benefit of significant research that the University of Colorado participated in to create what is considered the gold standard of therapy. So what are the most appropriate radiation doses, schedules, what chemotherapy drugs are the most appropriate? This gentleman also had the benefit of significant pathology. So this tumor, which was originally called the glioblastoma IDH mutant, has now been reclassified through the work of our neuropathologist and others to better define prognosis and define treatment. So this is now considered an astrocytoma IDH mutant 2 grade 4 tumor and not a glioblastoma tumor. And this tumor subset is associated with better prognosis, which may be why this gentleman has had 5 years without tumor recurrence for a tumor that has a median survival of about 12 months with a 5-year survival rate of about 7%. So the other thing that kind of I want to point out is the pathology slide that you see there in the bottom middle is what we used to completely make diagnosis based on, which is how cells stained looked under the microscope. But now with tumors, neuropathologists have to identify features that they see under the microscope, as well as a cadre of genetic mutations, using transcripts, and other things that help define exactly what these tumors are. If you want to forward the slide. So when we look at neuro-oncology, it's a very multidisciplinary field. So in order to treat patients, we need to advance our imaging techniques, and Dr. Lily High is going to talk about this a little bit more. Our surgical techniques, the provision of local therapies, the precision pathologic diagnosis and the molecular characterization of these tumors so we can better define what tumors have the best prognosis, what tumors respond best to what therapy. Optimization of radiation therapy delivery, especially the minimization of side effects, as well as trying to shorten the treatment time frame, which is associated with better quality of life because patients are spending less time here on campus. Developing new therapies such as tumor treating fields, as well as different chemotherapies, targeted therapies, vaccine therapies, immunotherapy, some of these things that Dr. Messersmith is going to highlight in his talk. The other thing that we are part of is new clinical trial approaches. And I want to discuss this a little bit further because the GBM Agile platform study and basket trials are something that we are quite excited about in the neuro-oncology group. You want to advance this slide. So traditionally, a clinical trial looks at one disease and one drug and seeks to determine if that drug is effective for treating that disease. So more recently, we have the development of something we call master protocols. And this is most commonly used in the oncology space, but it's also used in other diseases as well. And these master protocols include the basket trial, the umbrella trial, and the platform trial. And what these trials are designed to do is to try to more rapidly identify therapies as well as confirm effective therapies so that we can then offer these and translate these into patient cares. So a basket trial is a type of trial that tests one drug in multiple different diseases. In oncology, these are often exploratory trials looking for finding a signal of disease effect. An example of a basket trial that has been beneficial for neuro-oncology is the drug vemurafenib. This drug was initially FDA approved for the treatment of melanoma with a specific genetic mutation, the BRAF V600E mutation. A basket trial which looked at treating vemurafenib with any tumor that had this particular mutation found that folks that had Erdheim-Chester, which can form mass lesions within the brain, responded very effectively to vemurafenib, and this has led to FDA approval of this drug for an extremely rare disease that was never going to otherwise have clinical trials dollars dedicated to it. Umbrella trials evaluate multiple therapies in one disease or different therapies for multiple diseases, looking at trying to identify if preclinical data or a case study suggesting benefit, if that actually works to treat these. Here at the Cancer Center, we have the NCI MATCH trial. And this is a large phase 2 multi-center trial that's evaluating 30 different approved as well as FDA unapproved treatments that are targeting genetic mutations in multiple types of cancer. And brain tumor patients are one of those cancers that can be eligible for this trial. The platform trial is a very unique trial. This is a kind of a perpetual trial that's very dynamic, looking to evaluate simultaneously multiple different treatments. Treatments can come in the trial and out of the trial. There are preset determinations and interim analysis that would suggest that if the treatment is not effective, then that arm gets dropped. So we're not treating patients with an ineffective therapy. If something new comes along, those get introduced. And so we can more rapidly identify what is the most appropriate dose, what treatments may be better than other treatments, and get that information to our patients much more quickly. So this is a very flexible design. Here in the Cancer Center, the Neuro-Oncology Group has the GBM Agile trial. We are one of 30 centers in the United States that are offering this trial to our patients. If you want to advance the slide. So if we look at what philanthropy contributes to our brain tumor program, we are a very multidisciplinary program. We try to learn from each and every patient that we see. And we use this information and dollars from philanthropy to do extra things with our patient care that is not billable to insurance. With this, we have been able to characterize toxicities in therapies. We have been able to research and identify new treatment targets and better understand drivers of tumor growth. We frequently do autopsies of very unusual cases in order to try to better understand tumor behavior. We have a tissue bank, which we use for research projects. Our pathology group is very vigorous in looking for the molecular characterization of tumors, which often requires doing multiple stains and other things on a research basis that aren't billed to insurance. We do clinical trials, and another thing that we do frequently is quality of life projects, looking to try to improve the quality of our patients' lives with various changes in the way that we approach these tumors and tweak their therapies. And with that, I will turn things over to Dr. Lillihei, who's going to talk to you about some new technology.
Great. Well, thank you to Dr. Dominic. So what I'm going to do is just kind of give an example of some new technology that's helped us with treatment of this group of patients, and particularly helped us with diagnosis and with surgical treatment. So this is a 58-year-old right-handed female who presented to our department with about a year history of headaches. And the headaches had gotten progressively worse over time, being particularly severe about 4 to 5 months before she came to see us. In retrospect, she had also noticed the onset of fatigue and difficulties with her short-term memory. And then about 2 months prior to presentation, the headaches were so bad, she ended up in an emergency room with a CT scan that was very abnormal. About a week later, she underwent an MRI scan, which showed a 2.1 by 1.8 by 2.4 centimeter mass on the left side of her brain in a region called the ventricle. So if we can advance the slide. This is the MRI scan of this patient, and shown on the left is what we call an axial view, or a horizontal view of the head. And then the middle picture is as if she was looking straight at us. The right ear is over on your left side, the left ear on the right. And you can see this tumor is sitting in a spinal fluid space deep in the brain in the left hemisphere. And the picture on the very right is a side view showing where the tumor is. Well, not the largest tumor in the world, but it is now causing her symptoms. And the problem is that this tumor is lying deep in the left hemisphere. So in right-handed patients, virtually all right-handed patients are left brain dominant. And what that means to us is that's the area of the brain that controls speech and communication. And interestingly, left-handed patients, still 80% of left-handed patients still have the left brain as being dominant. So the challenge in this particular case was, how do you get to that tumor without causing problems? And if we can show the next picture. The picture in the upper left is kind of a image of the brain, and this tumor is sitting right below the language comprehension region. So to approach this tumor, we need to somehow come behind the motor. The yellow strip there is the motor cortex. Behind that is the sensory cortex. We need to be back behind that, but we can't be back so far that we're into the visual cortex, which is the occipital lobes. So our approach has to be through language comprehension, or we need to figure out a corridor that we can get there without causing language dysfunction. The image on the upper right shows the superior longitudinal fasciculus. Those are the fiber tracts in the brain that connect speech with the communication, with comprehension of speech. So those are important fibers that if you try to go through those, which is the most direct route to the tumor, you're going to cause significant problems, not only with the patient's ability to speak, but also to understand what people are saying to them. The image below that in the right lower shows the motor tracts. Those are the important fibers that control motor function to the other side of the brain. In order to get to this tumor, you need to be behind those motor fibers. And then in the lower left, vision. The green fibers are the optic radiation. So you can't go at the tumor from the side, or you're going to go right through the optic radiation. So this created a big problem as to how we approach this. But using these images, which are generated for this patient, each patient has a series of tractography and functional MRI scan images, we're able to go to a workstation and then plan a corridor or an approach that we can avoid these structures. And at the next picture, if you can advance the slide, basically in the lower left, you can see kind of a red line, and the approach to this tumor that would cause the least amount of neurologic deficit and hopefully no neurologic deficit was to go down in between the hemispheres of the brain, go down to a set distance as determined by the computer guidance, take a left-hand turn and basically approach the tumor. You can kind of see the lower right-hand picture that shows the tumor being have been evacuated, and the only portion of the brain that was entered was that very inside area. And this is done by using what's in the upper left, an operating microscope, and in the upper right, using intraoperative computer navigation. So this is technology that has been present now for about 5 to 10 years. We've been a very big part of bringing this to the forefront and using this. But thanks to we can go to the next slide. All of this technology is based on two-dimensional imaging. The next step right now is to use holographic imaging, three-dimensional imaging. And due to the generosity of some of our grateful patients, we now have begun research in this holography. And Marty, if you can press this is an example of what the imaging is like now. Using this as an educational tool, the hope is to be able to bring it into the operating room at some point for surgical planning. This is the actual image projected in three-dimensional space right in front of you. Anywhere in any room, you can project this image and walk around it. And you can take the image and you can spin it, you can walk around it, you can actually enter into the image and see deep into the brain. Here you can peel over the layers. So really a completely different way of approaching these tumors using three-dimensional imaging. And I think we're good there. Thank you, Marty. Continue. You can continue it. All right. So thank you. Yeah, and I'll turn it over to Dr. Messerschmidt.
Great, thank you. And Marty, I just want to do a quick time check. So when are we going back to the main session?
We'll be going back to the main session in about 17 minutes.
Okay, great. Okay.
So we're good on time. Yeah.
Okay. I want to leave enough time for questions. Yeah. So I'm going to sort of switch gears here and talk about immunotherapy. And one of the best examples of that is this subset of colorectal cancer. And I put in some abbreviations that are spelled out, but that have mismatch repair. And that basically just means that your spell checker is off on your DNA, and you're not able to repair mistakes that crop up when we're copying and making new cells with dividing cells and making different copies of DNA. And turns out that we have these repeats called microsatellites. And so when the editing function is turned off, you get a lot of different versions of it. So it's also called microsatellite instability. That's what that MSI or MSI stands for. And next slide. So if you look at mutations across multiple tumors, and it's a little bit small type, but you can kind of see in the bottom various tumor types are listed. And then as you work your way to the right, you see tumor types that have higher mutation rates. It's sort of interesting if you kind of pause and look at this. For instance, glioblastoma is sort of in the middle of the picture there. And as you get out to tumors that have a lot of DNA damage, like melanoma, all that sun, today was not a good day to be outside without sunscreen. I get a lot of DNA damage there. Lung cancer is another one. All the things that we're breathing in all the time, bladder cancer, stomach, etc. But colorectal cancer is not very responsive to immunotherapy, the typical type. And we think that's because there aren't enough foreign proteins that are driven by these DNA mutations for the immune cell to recognize as being a foreign, cell that needs to be destroyed. But if you have your editing function off in these tumor types, and that can either be inherited or it can crop up in the tumor itself, you have 20-fold higher DNA mutations. So you take someone who has a colorectal cancer which is normally not very responsive to immunotherapy. And they now have more mutations than your average melanoma, lung cancer, bladder cancer, et cetera. And they become much more responsive to therapy. Next slide. So this was one of the first New England Journal articles. And speaking of philanthropy, this was interesting because we were actually asked by my colleagues at Hopkins at the time where I had trained and had been a faculty member to participate in this study, but they actually didn't have any funding. And so this would be an example of where philanthropy could really help us by being able to do a study that did not have government funding and it didn't have industry funding. But what happened here is you see these bars and you notice that the black and the blue bars are downwards, and that's what you want. This is basically measuring tumors. And so you want to be pointing down past that 30% decrease if possible. And what was interesting about this is that, and it kind of gets back to Dr. Damick was talking about some of these trial designs, was that whether you had mismatch repair deficient colon cancer or even non-colon cancer, so it doesn't really matter where it came from, but if you have that characteristic of having an editing function that's not working, you were able to respond to these drugs called checkpoint inhibitors. Next slide. And not only that, but these immune stimulating drugs, what was pretty impressive about it, and this is basically measuring, it's called a spider plot. You're just measuring how the tumors are responding over time. And what was really impressive was that these responses lasted for a long, long time, going up to years. So you see 365, you see 730. So typically when we give therapies, you get resistance usually within a few months. And in this case, these responses lasted quite a long time, which is super impressive. And I've had patients where basically once I got them on immunotherapy, if they had a nice response, we were able to basically stop therapy, and all the follow-up scans, they really haven't shown recurrence. So if you can get the immune system turned on, you can have what appears to be a cure. What was really cool about this is that we knew about this data about 2 or 3 years before it came out, and we were able to put patients who had been enrolled in hospice onto our trials and basically save their lives. They're working full time and back to normal life. Next slide. Well, this microsatellite instability or deficient mismatch repair, I told you it's a small subset, and it's true. It's only in 3.8% of all cancers. But these small percentages add up, and in fact, you're looking at over 65,000 cases a year. I happen to do gastrointestinal cancer, so I've highlighted some of the GI ones. But there's each one of these colored bars represents a different cancer type, and these small percentages really add up. Now you can have inherited defects in your editing function. That's called hereditary non-polyposis colorectal cancer. It's also called Lynch syndrome, and that comes with endometrial, colon, gastric, and rectal. So those are the most common, but there's other ones too. So esophageal, cholangiocarcinoma, hepatocellular, there's thymic cancer there, head and neck, sarcoma, many other types. GBM, there's that little blue one all the way to the right. They found a couple of brain tumors there too. But these small percentages can actually add up, and you can have a big impact, even though it seems like it's just a small percentage of people when you're first starting out. Next slide. So these checkpoint inhibitors basically take the brake off the immune system. A checkpoint is essentially a brake to try to prevent the immune system from becoming overactivated. And by inhibiting that, you're basically taking off the brake. And these specific subtypes of patients seem to benefit the most. And we've seen success of these drugs really across multiple tumor types. And here at the University of Colorado, we're very well positioned because a lot of really important immunologic science has been done here historically, getting back to that history that Dr. Schulich talked about in his talk. The T cell receptor was cloned here, for instance. Some of the interleukins were discovered here. And then the Cancer Center has over 300 clinical trials both from industry partners, but also ones that are investigator initiated. That means basically that the scientists here are basically writing and starting a trial. And this is where philanthropy is just critical, because these trials can cost $1 million to do, and having philanthropic support to conduct these trials is incredibly important, and they really wouldn't be possible were it not for our partners in philanthropy. And I'll stop there. I'm happy to take any questions.